Federally qualified health centers, or FQHCs, will soon be subject by law to the Merit-Based Incentive Payment System, or MIPS. This means that part of their funding will be at risk, based on whether their patients get healthier. This is known as value-based funding. Payment reform makes sense. Our healthcare system should encourage providers to do what it takes to get patients healthy. MIPS is a huge change for FQHCs, who are used to being paid for the provision of services, not for patient health outcomes. Our goal is to improve the health of those least served, not to count the heads of those least served. And with this grant structure, we pay for what we really want: healthier patients. Starting in 2017, we changed our funding for FQHC partners to value-based grants. If patients hit a targeted level on health improvement for a comorbidity, FQHCs receive an additional amount of money for each comorbidity. The funding is completely flexible. FQHCs can spend the grant however they want to help get people healthier. We receive patient-level data for deep analysis of what works. So far, the results have been very positive. The most striking change has been how FQHCs have been able to innovate using the flexible funding. Some have developed completely new programs and practice changes, including nutrition and exercise support services and higher touch models, such as case management and home visits. By using Methodist Healthcare Ministries funds to reduce or waive co-payments, they have also seen improved patient compliance, which of course makes their physicians happy. And last but not least, patients have gotten healthier. 86% of patients showed improvement on at least one of the comorbidities during 2017. As Albert Einstein said, anyone who has never made a mistake has never tried anything new. We learned alongside our funded partners in exploring this new payment structure. We didn't know what we didn't know, one partner said recently. It's all about the details, and you only learn those lessons through experience. It's important to gain consensus on the metrics to be used and the amounts in the payment structure. We tracked 4 core metrics in 2017 related to comorbidities in the patient panel: HbA1c control for diabetics, blood pressure control for hypertense patients, PHQ-9 symptom reduction for depressed patients, and BMI reduction. Except for the BMI reduction, which was too challenging for a 1-year period, most of the health centers did very well on the outcomes. It's important to use nationally benchmarked metrics, such as those with a Medicaid average, metrics aligned to MIPS, or Healthy People 2020. That means the bar is set in a realistic place, and the FQHCs are likely to be tracking those things already. The funder has a responsibility to set metrics realistically, as setting the bar too high can cost the FQHCs money in this type of payment structure. Low-income uninsured populations tend to be more transitory. They could move, get a job with health insurance, change phone numbers, or lose their transportation. If this happened in the first half of the year, we allowed FQHCs to replace them within limits. We wanted to be sure there was enough time for the newly added patients to get healthier. Until one partner had to start reporting, they had no idea it would take their physicians 7 hours a week to pull the data that they would need for MIPS. They were able to modify their EMR templates and reporting system to make it faster and more efficient. That will have benefits far beyond the Methodist Healthcare Ministries grant. We recommend that any funder trying this model be prepared to provide technical assistance with data management. It's important to define everything. Small differences of meaning or interpretation could affect how much money an FQHC receives. It's important to be clear up front about what qualifies for an incentive payment, when they will receive disbursements, what patients are eligible for panels, and which diagnosis codes qualify for each comorbidity. FQHCs need flexibility on co-payment rules. In 2017, we required a co-payment waiver. This was a problem for some FQHCs, as they found that patients talked to each other and weren't happy that those in the panel didn't have to pay. For 2018, we are allowing partners to charge a copay, but are capping it at $20. Interestingly, many of the FQHCs have chosen to keep the total waiver because it improves patient compliance. People are more willing to come in for follow-up visits if they don't have to shell out the additional cash. We were learning alongside the FQHCs, so we were humble about any mistakes that were made. We learned by listening. We admitted mistakes and made any course corrections we could. For example, we changed the PHQ-9 metric to a tiered structure, which allowed a more modest change for mildly depressed patients. We had expected that, on average, most patients would come in at higher levels of depression, but that wasn't true at some of the centers. What's next for the Methodist Healthcare Ministry's value-based funding model? In 2018, we have added prevention metrics to supplement the disease management and obesity metrics. We have also changed our metrics to be aligned with national benchmarks and MIPS metrics, which we believe will make them more realistic and attainable. We are also commissioning a software company to build a cloud-based reporting system that will make it easier and faster for the FQHCs to report to us. The bottom line is that the experiential learning so far has been deep and detailed, both for Methodist Healthcare Ministries and for our FQHC-funded partners. No workshop can teach FQHCs in this much depth what they would need to do to modify their EMR templates or change the way their physicians chart, for example. This is the great value of this program. Because they have learned through experience, FQHCs will be better equipped to handle MIPS when millions of dollars, not thousands, are on the line.